Thank you all for joining our full disclosure webinar today, Breaking Up Big Medicine, Why Independent Pharmacy is Key to Better Benefits. I'm Alissa Johnson. I'm the Senior Director of Clinical Strategy at SmithRx and thrilled to have Benjamin Jolley joining us today to go through some of his expertise and experiences with independent pharmacies. And so, Benjamin, would you give us a background on yourself?
Sure, yeah. Briefly, I am a third generation pharmacist. I work with my dad at Jolley's Compounding Pharmacy, which my grandpa started in 1954, so we're going on 72 years next month. Um, I have worked there since I was very young. I was 14 years old when I started clerking, and I've done all of the things in the pharmacy, helped people get their medicines by delivery. I was a technician, filling prescriptions, intern, and I'm a pharmacist. Um, I also started a consultancy for other pharmacies to help them understand how how insurance benefits and pharmacy benefit management works from their perspective, called Apex Pharmacy Consulting. And I'm also a senior fellow for healthcare policy at a nonprofit in Washington, D.C. called the American Economic Liberties Project. We focus on making sure that the economy is fair for everybody, not just the largest, biggest, baddest people.
Yeah, and your family really does have a legacy. We're both in Utah, and I went to the University of Utah a long time ago, and the intern jobs and rotations at Jolley's Pharmacy were the ones to get during pharmacy school then because it was such a great experience to be able to work alongside pharmacists and interact with patients and really get that experience of providing patient care. So, thank you so much for joining us today. Now we'll go through the agenda. We'll first talk about the state of the independent pharmacy and especially the value of community pharmacies and pharmacists. And then we'll go through some examples of the legislative battlegrounds and what is a reasonable path forward for sustainability. We will have question and answer at the end, so please drop your questions in the chat and we will do our best to get to them. If we don't get to all of them, we will email you. In looking at the state of the independent pharmacy, so much has changed in healthcare, even just the last decade, between drug spend changes, new drugs to market, COVID, and everything else. Benjamin, what have been the overall market trends for independent pharmacies over the last few years that you've really seen as a pharmacist?
Yeah. So there's been since I started working as a pharmacist in 2018, there has been massive consolidation in pharmacies. Um, I mean, just in where I started, where I was in St. Louis during pharmacy school, and um, there are three regional chains that no longer exist in the St. Louis market. They've all been bought by CVS. Rite Aid no longer exists. Um, and since I started working like in 2004 in the pharmacy when I was very young, um, we've seen also just a dramatic shift of cost of pharmacy from um, lots of high cost, very commonly prescribed medicines, not really very high cost relatively, but like brand name Prilosec and brand name Nexium and so forth, to almost everything being dispensed as generic now, and um, and most of the medicines that I see in my day to day are generic medicines that are very inexpensive. Um, but at the same time, there's been this concentration of money into a relatively small number of products for a relatively small population of people that we call specialty. And that has mostly been excluded from our pharmacy. When I started practicing, we did a fair amount of specialty products, but since that point, um, more and more of these products have been steered to so-called specialty pharmacies that are mail order owned by a pharmacy benefit manager. Um, and so, um, in addition, there's been a significant trend of a lot of small pharmacies like ours closing. We are still sticking it out, thankfully, but I I have several personal friends that have had to close their pharmacies due to um, unacceptably low reimbursements from some pharmacy benefit managers, and so that has been tragic to watch. And I mean, also since I started working, Medicare Part D came onto the scene, which doesn't really affect employer benefits, but it certainly affects the pharmacy because something like half of all the prescriptions that a given pharmacy dispenses is probably to seniors. Um, and so that's been another trend is the Medicare Part D market has also consolidated dramatically. I looked just recently, and when Part D started in Utah, there were 53 Part D plans. Today there are 10 um, that are offered by 5 carriers. So you have the choice of the big 5 carriers. That's it. If you want to do Part D standalone. So that's those are all trends towards consolidation of power and consolidation of finances into a relatively smaller group of companies.
Yeah, and that script volume can be significant where maybe even though it's a lot of generics, it may not seem like a lot when it moves over to the big chains, but you get enough volume and that certainly makes a difference. And in terms of how many, you had mentioned the PBMs own pharmacies. What are some examples of the cost differences once a script is steered to a PBM owned chain?
Yeah, I mean, so this is not just specialty, right? Um, I get steering edits on prescriptions. I'll bill a claim and it'll say refills are not covered, and then it will say, please inform the member that they can either pay full cost at your pharmacy or they can transfer to CVS. A lot of times, not always, but a lot of times the PBM there is CVS Caremark. And so just this slide that we're looking at shows the level of vertical integration that just CVS represents in this space. They are the insurer, Aetna. They are PBM, CVS Caremark. They have a group purchasing organization for their PBM for sourcing rebates, as well as a PBM for sourcing actual drug product in the form of zinc and red oak sourcing. They have the largest pharmacy chain in the country, CVS Pharmacy, as well as their specialty pharmacy, CVS Specialty. They run a third-party administrator. They have their own drug manufacturer, which I think cutely is Cordavis, CVS in that name. And then they also own physician practices, not just Minute Clinic as is listed here, but also um, Oak Street Health. And I think there's one other that they own as well. And so they can. There was recently a congressional hearing where the congressperson questioning the CEO of CVS said, "What does this do for the consumer?" And he said, "Well, I think it gives them better health outcomes." And then she said, "Well, here's what you said to your investors. It gives us an opportunity to make basically a whole bunch of money." A fully engaged member is what they call someone who uses the full stack of their benefits. We were asking specifically about price differences. And so when I see prescriptions get steered from my pharmacy to a CVS, for example, there's price differences between what CVS pays their own pharmacies and what they pay me. You can see this as plain as day if you just go on medicare.gov/plan compare and you say, I want to use CVS's Silver Script and I want to know how much money the plan will pay Jolley's versus pay CVS. And you can see that for some medicines, there is a dramatic price difference. To a more concrete example of this, the state of Tennessee prohibits this behavior of paying your own pharmacies more than competitor pharmacies. And so they audited, is this something that actually you comply with, right? Are you actually paying other pharmacies appropriately? And I think interestingly, the CEO of CVS was in July of 2024, which this audit was of the year 2024. In July of 2024, he was dragged in front of Congress and he said, "We pay independent pharmacies 15% more than our own pharmacies." And yet, this audit found that that was not the case. And not only was it not the case, it was dramatically not the case. As just one example, the most extreme example among there were a lot of these, but the most extreme example, CVS reimbursed a CVS pharmacy $8,000 for cinacalcet on the same day that they reimbursed a independent pharmacy $50 for cinacalcet. This is one drug, but that was a 160x price difference, right? That is just crazy. Like just thinking about this, you could treat 160 people with kidney disease at the independent pharmacy or one member at CVS. That is a mind-boggling amount of just taking, I guess, because you are in the position where you can. And similarly, they did the same thing with many other drugs, tadalafil as well. So it's really shocking to see this, and so it creates, though, this situation where independent pharmacies are forced into a position of, okay, well, where do I find money? If I'm getting paid $50 for this and CVS is getting paid $8,000, they can run a pharmacy that has a different efficiency standard that they have to meet than me in terms of and has a different profitability standard that they can meet, while still just filling the same number of prescriptions. So it creates a very unequal playing field that's really frustrating. And like, I don't want to be paid $8,000 for a drug that, honestly, the $50 price is reasonably fair. I just don't want to have a situation where I have to fill 160 times as many prescriptions to be equally profitable. I hope that makes sense.
Yeah, it's huge and usually the exact opposite of how things usually are. If you go to a wholesaler, just in the usual retail setting, like Costco or Sam's Club, you're going to get discounted rates when you're with the bigger chains versus an independent store. But this is the exact opposite. These are unheard of markups, and with all these vertical integrations, what have you seen with regard to the guidance the FTC offers?
Sure. So the Federal Trade Commission did they are still in the process of performing a so-called 6B study. Section 6B of the Federal Trade Commission Act gives them the authority to basically say, you're going to do a study of yourself and you're going to give us all of this information. So they've done that. They're still in the process of doing that, but they've released two so-called interim reports that both found just fascinating data. You can see here the markups. This was relative to the cost to acquire these drugs. So if you take the cost that the average pharmacy buys drugs at, not a giant pharmacy that can bully their suppliers into lowering the price, but an average pharmacy, and honestly an independent, will buy this drug for, say, $100. They would mark it up 7,000%, as you can see here. And there were also some, I think, interesting just statements in this FTC report where in some internal communications between OptumRx executives, one one of them described it as bad optics that we pay our own specialty pharmacy $11,000. No, it wasn't. It's like $8,000 for imatinib, where someone can get that same medicine at Costco for $100. It's bad optics, and it was in a Medicare context specifically, so it's not just bad optics. It's taking advantage of your position as a federal government contractor to pay yourself more, which I think is maybe worse. But that massive difference between $100 at Costco versus $8,000 at the pharmacy that they control is, I think I would agree, bad optics for them. And they're like, we should probably change this. So anyway, I highly encourage anyone who's really interested in this to just look for FTC interim report PBMs. It's a doozy of a read. It's a ride. You find all sorts of interesting factoids and concerns of how especially the largest PBM pharmacy ownership is being used to make a lot of money for these very large companies at the expense of the general public.
Yeah, there's a lot of claim shifting happening, steering, and price changes. We've talked a lot of numbers with regard to what it looks like when these drug prices are really inflated and much higher than probably what they should be, and then also at independence. But how is this, at the end of the day, how is the price gouging and claim steering impacting independent pharmacies and their bottom line? Is it sustainable?
Yeah, I mean, from a, like, frankly, no. I mean, if you have a situation where someone says, okay, this is our budget for drugs, and you have one company who is controlling the pharmacy benefit consuming half of the money for their own 10% of the prescriptions, the pharmacies that aren't in that same ownership structure are going to be cut in their reimbursements. And you can see on the page here, this is the sales have increased dramatically for typical pharmacies, for small business pharmacies over the last several years, mostly because GLP-1s have increased. But frustratingly, every time I fill a GLP-1, almost every time I fill a GLP-1, we lose money because since they're such high dollar volume, high cost medicines, our wholesaler carves them out of our usual supply arrangement, and so we buy them at a higher cost than other branded products, and we get reimbursed below our cost for a typical GLP-1. So we buy an Ozempic for about $1,000, and we get paid like $930, $900, $950, somewhere in that range. So we're losing $50 every time. The only way to make that make sense is if somewhere else in that patient's profile there's something that's making more than that much money, which it just feels like the incentive that creates for pharmacies, I think, is really poor. It means that people seek out questionable arrangements, like weird drugs that have a weird price problem with them, and so you make a lot of money on them. And that happens, but I think that if we had a situation where people were being paid fairly for every prescription, that kind of fishing for weird drug situation wouldn't happen. But as you can see, like even with any kind of work that people do to try and raise their profits in sometimes questionable ways, the profits overall have dropped pretty substantially over the last just since the beginning of COVID. That chart, you see that spike in profitability, that's COVID vaccines. And then ever since then, it's been more and more GLP-1s, which have, again, negative profits, which brings down the overall profits for a pharmacy while making the sales numbers go dramatically up.
And we've been talking a lot of numbers here because, any pharmacy is a business that needs to operate and make decent margins to be able to be successful and sustainable. But being a third generation pharmacist and working in the community as long as you have, the cost to operate is one thing, but really the value of community pharmacies is huge in that pharmacists are the most accessible healthcare provider. And there's a lot more that goes with this beyond drug pricing for patients who come in to the pharmacies. And so, what are some specific examples of really what is the advantage of independent pharmacies that gets missed in all of these pricing discussions?
Okay, so what are some things that get missed when we're talking just straight up price, right? Is like the value of having local control of a pharmacy to me is very meaningful. When you talk to a pharmacist in a chain pharmacy, a CVS, or a mail order pharmacy, they are not ultimately the decision maker of how policy gets made in that pharmacy. Does the pharmacy carry this drug or this brand, or do they cut their staff? Do they who sets the labor budget? Who that they are not in control of those factors. They might have some influence on them, but with a locally owned pharmacy, in a lot of cases, you can either talk to the person who owns that business right across the counter from you, or you can say, hey, can I talk to them when they're in next week, right? And so there's a much more local control element, and that person can, so if you have an issue with how the pharmacy is being run, you know me. Like, if you come to my pharmacy, you can see me there, and you can say, Ben, I don't like the way you've done things, right? I think that's a very meaningful thing that you lose with large chain pharmacies, where there's not just the pharmacist, but then there's multiple layers of management before the person who's ultimately making decisions of how it's staffed. And one of the things that I think is honestly kind of depressing is that differentiation in pharmacy has become very simple over the last couple of years. One of the largest chain pharmacies implemented a system where their phone calls do not go to the pharmacy staff anymore. They go to voicemail directly. You talk to a little AI voice agent that transcribes your call, presents it to the pharmacy staff to call you back, which means that, you can't actually talk to a human until they call you back. And so just my picking up the phone and saying, hi, this is Benjamin at Jolley's, how can I help you, is a difference between me and the largest chains, which is sad, but that is one of the small factors that, like, just yesterday I was at the pharmacy and someone called and said, hi, my son is taking this medicine, he's sick, can I give him this other medicine, is that going to have an interaction? And I was able to say, let me look real quick, no, there's no interaction there, that's fine, you can go ahead and give it to him, he will be fine. And I think that level of accessibility gets lost, and that level of, like, local accountability gets lost as well. Like, I'm sorry, like, working in a chain, there's a lot of times a situation where, I'm sorry, that's not my decision, that's corporate, you can take it up with corporate, right? Where in my context, there is no corporate to answer to. It's myself and my dad, right? We are corporate. And so if you have an issue with how we do things, well, then you can talk to me. There's disadvantages to that. I mean, certainly it means that I have more things to worry about, but it has, I think that level of accountability locally is very important. And I mean, additionally, like, there's just, I think that the ability to set the labor budget is also a very meaningful differentiator there, right? We do need to make money. We do need to not have our pharmacy go out of business, right? We do have some constraints there, but we don't have to answer to Wall Street when we set our labor budget. We have to answer to ourselves, right? And so when we say, I think that we could use another person around here, let's hire them, rather than, okay, well, your labor budget is you get 29 technician hours to do 5 times as much work. There's this meme that I've seen online, which is just comparing the staffing in a Walgreens from 20 years ago to today, and it just says 2006 pharmacy team, Walgreens team, 2026 Walgreens team, and the 2006 team is like a picture of like 30 people working in one pharmacy, and the picture today is 3, and they're filling more prescriptions. And I don't think that's because that's strictly financially necessary. It might be. Maybe they've agreed to very, very low reimbursements where they have to do that. But I think a large part of it is the desire to make profit for shareholders. That while we also have to live with our choices, right? If I want to make more money, that means I have to work harder, right? Or if I want to have a little more help in the pharmacy, then we make a little less money. But that to me is a key difference.
Yeah, and you mentioned accountability, and there is a component here that you've alluded to where you're accountable to your patients that come in and how you address them and how you provide access to a pharmacist for them. And that's one of the biggest things we see in outcomes is that when people can have access to a community pharmacy, they can better take care of their long-term diseases. So for like diabetes or others that you see a lot of patients for, can you give us an example of when that's made a difference and you kind of think in the back of your pharmacist brain like, whew, I'm really glad they weren't just at a big chain and that I could help them today. It changed
Sure.
it.
Oh yeah. I mean, okay. So 2 weeks ago, I was processing prescriptions for a patient who has diabetes. She had her prescription sent to us, and I looked at her regimen, and like she'd been going to a charitable clinic, right? So relatively low income, but she was insured. She did have like a good plan, and her doctor had prescribed medicines that are very inexpensive, but relative to other medicines that are available, ineffective and more likely to cause long-term harm. And so I looked at her plan's list of covered benefits, list of covered drugs, and looked at alternative medicines. And we got her switched from her some medicines that like squeeze insulin out of the pancreas and slowly kill the pancreas and make diabetes over time more brittle, to some more modern therapeutics that are more appropriate for her condition and that are protective against heart attack, protective against stroke, and have better evidence of lowering her sugars. And so I sent a message to her doctor and said, "Hi, here's the situation. I think we can get these medicines, and her cost will be comparable to even less in some cases." And so I was able to help her pick different medicines that were more appropriate. Like her choice of clinic, it makes sense the way the doctor's brain ran, but like she was insured, she did have a good plan that had coverage, and so there was no reason to be choosing these very old therapies other than that's what this person is used to prescribing. Another example was just, this was 2 days ago. No, today's Tuesday. This was on Friday. On Friday, I spoke to a woman who she was picking up insulin for her son who has type 1 diabetes, and also she herself has type 2 diabetes. And she was picking up a continuous glucose monitor for her son as well as his insulin. Um, and we started talking about her therapies for her, um, and what options she had. And I mentioned, you're getting this continuous glucose monitor for your son. Continuous glucose monitoring is not just necessarily for people who need insulin. There's definite evidence of benefit there, but you can also use it in earlier stages of diabetes. And so she decided to pick up an over-the-counter glucose monitor for herself. Because there's good evidence that something like just the act of monitoring glucose with a CGM lowers A1C by half a point to 0.7%, which is a meaningful reduction. In her case, her A1C was only about 8%. And so getting her down below 7, she would get most of the way there just with monitoring on that basis. So I think that's a meaningful thing. And controlling diabetes means we prevent blindness, we prevent heart attacks, we prevent strokes, we prevent kidney failure. And so I think that getting my patients' diabetes under control is a really meaningful thing.
Yeah, those are some powerful examples, and it's just once again goes to show just how much information patients get, and that like they walk out of the doctor's office, there's still a lot of other decisions and sequence of events too that they need support on, and the pharmacist is there for that and helping to optimize. And thanks for sharing those. And of course, we know the value of independent pharmacies, but can you shed some light on what it looks like with the shrinking footprint of pharmacies? Meaning there have been a lot of closures. And what does this mean for communities where they may no longer have any or much of a pharmacy presence?
Yeah, this is a issue of personal concern to me. My pharmacy is not in a rural area, right? We are in Sugar House, Salt Lake City, like very urban area. Several pharmacies in our neighborhood. So like our pharmacy closing would be a tragedy for our patients, but they would get care without a lot of difficulty. But one of my closest friends grew up in Hopkins, Minnesota, where his dad ran the only pharmacy. His dad later sold it to a small chain who just 2 years ago closed that pharmacy. There is now no pharmacy in that whole county. There are, as you show here, there are over 100 counties that have no pharmacies at all. This is sort of a part of a broader trend of some parts of the country are seeing structural decline, not just in terms of like access to healthcare, but in terms of local economic opportunity. And from the perspective of like, what does this do to a community? Having a pharmacy is losing a local pharmacy is a marker that like they are in decline. It does a lot to the like tenor of the community that, okay, we don't have a place where we can fill prescriptions. We got to go to Walmart 50 miles down the road. But it's not just a like matter of local pride, but it's also there's an impact on people's health. There was a study done in JAMA not too long ago that demonstrated that when a pharmacy, particularly in a rural area, closes and there's no longer access to be able to pick up prescriptions in a local context, there is an increase in ER visits. There's an increase in non-adherence to medications. People stop taking their medicines, and there's even an increase in mortality. People die as a result of not being able to access a pharmacy locally. more than they did when that pharmacy was open. Which, like, when you think about it, it makes sense. I mean, people get a lot of medicines their from their local pharmacies that don't just help them feel better, but they also take a lot of medicines that have a impact on their ability to manage diseases that are potentially life-threatening. Um, yeah, I mean, so there's an increase in mortality rate, ER visits, decrease in adherence, increase in claims because if someone is like, it is so much cheaper to treat diabetes with medicine than it is to deal with the consequences of diabetes later. Um, Metformin is, pennies per pill, um, and an amputation when someone loses their foot because they didn't control their diabetes is like tens of thousands of dollars, right? And similarly, like with high blood pressure, um, almost none of the blood pressure medicines have a particularly meaningful cost to a health plan. Um, like almost all of the antihypertensive agents I can think of are less than a penny or, maybe 10 cents a pill. And so per member taking these, the cost is extremely low. But the cost of someone not controlling their high blood pressures, they go into kidney failure, they go into um, heart attack and stroke, and that can result in either death, but also extremely high cost procedures, cardiac catheterization, um, dealing with a pulmonary embolus. Each of these is extremely high cost, and they're prevented by long-term treating with very inexpensive medicines. But if a pharmacy closes, people no longer have access to those very low-cost medicines locally, and in a lot of cases, they just give up on taking their medicines, unfortunately.
Yeah, and that's exactly what we don't want. We don't want to overspend on medications, but we don't want them to stop them entirely, either because they don't understand them or can't afford them, or don't have a pharmacy to fill them or know how to navigate it. And so, systematically moving back into the regulatory requirements, in looking at federal legislation, what are you seeing that hopefully would be meaningful to help nip some of this in the bud, where with the steering and difference in prices and PBM owned pharmacies?
Yeah, so like Congress passed a bill this year that doesn't take effect until 2029, but that does have some degree of effect on the pharmacy market, the Consolidated Appropriations Act. And so everyone in DC thinks that they're done with PBM reform because they passed a big bill and everyone's happy and we declare victory and go home. Um, that's my cynical take on how DC works. But more to the point, there is um, so Senator Warren and Senator Hawley introduced this bill called the Break Up Big Medicine Act. Um, it defines certain classes of common ownership of healthcare entities that the bill just deems beyond the pale and says, thou shalt not own these two things at the same time. So in the pharmacy space, it explicitly says you cannot own a pharmacy benefit manager and own a pharmacy. The opportunities to take advantage of everyone else by doing that are too numerous. We're just going to say no. Similarly, it prohibits insurance companies from owning physician practices. So I think that's also a meaningful thing. United Healthcare's Optum controls the medical practices of over 100,000 physicians. And there's a significant body of evidence that just like in pharmacy where CVS pays their own pharmacies substantially more than independents, United Healthcare pays Optum practices between 20 and 70% more than independent practices for the same caliber of services. And that I think is, I think that's wrong. I think that you should be paid approximately the same thing for the same service, not 70% more because you happen to be owned by the conglomerate. It also prohibits wholesalers, pharmaceutical wholesalers, from owning physician practices, which also I think is a concerning practice. There's been a dramatic uptick in wholesale wholesalers owning physician practices, particularly in specialties that use a lot of pharmaceuticals. And so this would also prohibit that. I think this is a very meaningful bill that would go a very long way towards addressing a lot of the structural problems that I perceive in the broad healthcare market. It wouldn't do everything. I mean, it doesn't explicitly get at hospital pricing, but it goes a long way towards dealing with a lot of these conflicts of interest that we see. I mean, and to me, it's common sense. Like, it is not legal for a auto insurer to own an auto body shop in most states. This is the exact same thing to me. You shouldn't be able to be a PBM at a pharmacy.
You had mentioned Tennessee earlier and some of their regulations and based on the pricing changes. What are you seeing? What's your take on the latest state level legislation in Tennessee?
Yeah, so Tennessee just 2 weeks ago passed the FairRx Act, which prohibits pharmacy benefit managers from owning pharmacies. It says if your corporation owns a pharmacy benefit manager, you cannot also own a pharmacy that is issued a pharmacy permit, a license to operate in the state of Tennessee. This was a really big fight. But this bill is expected to be signed anytime now. I mean, it might be signed today. It might be signed in the very near future. Who knows? But this would be the second bill like this that says you can't be a PBM and a pharmacy. That level of integration is just beyond the pale. And I think a lot of this came out of the results of that audit that their Department of Commerce and Insurance performed, where basically for the last 6, 7, 8 years, maybe longer, their legislature has repeatedly attempted to regulate the actions of the largest PBMs and say, you can't do this, you can't do that, you can't do this, you can't do this. You have to pay other pharmacies the same as you pay yourself or more. You have to do this. And the response from the largest PBMs was just to say, I don't care, we're going to do it anyways, so sue me. And so they said, well, fine, then your entire business model is illegal. So it's, I think that had there not been so much just blatant violation of their law, this bill would never have happened. But with the degree of repeated thumbing your nose at the state and its attempts to regulate these questionable practices, it has resulted in a situation where it's like, okay, well, if you're not going to follow the law, then sorry, we're going to make it impossible for you to break the law by making your business practice entirely illegal. So I think this is a very meaningful bill. It's the second bill like this. Arkansas did this last year, and unsurprisingly, the largest PBM sued and got a preliminary injunction. So that law is currently enjoined from being implemented. It would have otherwise gone into effect 5 months ago, but that's the Arkansas law, Arkansas Act 624. But I think, and there's also been some really interesting work out of, I think USC Schaefer it is, that found that breaking up So this is, yeah. So breaking up PBMs and pharmacies could result in a significant decrease in total cost of drugs, but also not just the like steering to your own pharmacies, paying your own pharmacies more game, but also um, cutting out a lot of the other practices could save a lot of money for the overall healthcare system.
Yeah, I kind of can't believe we got this far along talking about rising drug prices without mentioning rebates.
Yeah,
Because rebates are a whole other component here where if the person collecting the rebate, making and following the rebates is also the one owning the pharmacy, is also the one paying the claims, like that changes a lot. And really, where if a drug has a higher rebate, it costs more for the plan, it costs more for the member, and then who benefits at the end of it usually isn't the member or the employer. And so I'm glad you brought that up, because it's always kind of like the elephant in the room with these discussions. Well, what about rebates?
yeah,
And it just goes to show how convoluted so many of these contracts are, and why it's important to really make sure we have correct incentives in place for the business practices.
yeah. I mean, like the vertical integration in my mind, like it in theory, it could result in a situation that's like much cheaper for everybody, but it doesn't because functionally what it actually does is just offers the vertically integrated company 17 different ways to hide money, right?
Mm-hmm.
Um, oh, we can't have rebates? Okay, well, we'll just pay our own pharmacy more. Oh, we can't pay our own pharmacy more? Okay, we'll do spread pricing. Oh, we can't do that? Well, we'll form a GPO abroad that will collect rebates instead of us, and we won't pass any of those rebates along. We'll just pass along the rebates that we negotiate. And so, like, the more convoluted the ownership structure and vertical integration gets, the more opportunities there are for someone to scrape a small amount here and a small amount there, and it adds up to a lot of money for the people who are ultimately paying the bill.
Most definitely. And as everyone on the call knows, SmithRx is a PBM, so you're also probably wondering, why is this conversation happening like it is if PBMs don't work well with independents and drive up costs? Well, not all PBMs are created equal. I would say definitely seek out modern PBMs. SmithRx, we don't own any pharmacies. We'd much prefer to work with local independent pharmacies and let them have the impact on the community and decide how those business practices should be. And we really want to do it in a sustainable way. And so over half of our contracts are cost plus contracts, meaning we know that the pharmacist and pharmacy are getting reimbursed fairly because they get a fee on top of the acquisition cost of the drug. And we feel strongly that sustainability and transparency go hand in hand, so that our SmithRx members can continue to get access to these local independent pharmacies and be able to afford their drugs. And along those same lines, we just do our best to really have fair contracts and meaning sustainable reimbursement rates for the pharmacy, so that we can remove any incentive. Steering isn't a concern, which also means there's not another lever driving drug costs up. And at the end of the day, we can offer low cost options. The other component of all this is we have a lot of drug pathways that help guide members for what medications and where to fill them. So we really want to keep consumers empowered in understanding, where can I fill my meds and what are the cost differences. So we have tools for our members so they can find their local pharmacies, compare the prices, and make those informed decisions that work for them, completely outside of what happens with the pharmacy reimbursement structure. And so hopefully it can just be a win-win, where they're informed, they understand what the cost of their drugs will be, they're able to see local pharmacists like Benjamin and get the additional clinical care while they're there as well. All right, we have some questions in the chat. Thank you all for those. Benjamin, you really follow regulations closely, and clearly you're passionate about it. If you could have a magic wand and change one specific regulation tomorrow, what would it be?
Um, if I had a magic wand and I could just do it by myself, like no one else has to be convinced, the pharmacist in charge of a pharmacy has to have at least half ownership of the pharmacy. Um, that like North Dakota has this on their books. That should be the law. Um, because that person is legally responsible for what happens. They should be also accountable to the community by being in a significant ownership position as well.
And yeah, investing local, not just for the sake of the license, but also the livelihood of the pharmacy. That makes sense. How does an independent pharmacist like you help with adherence and medication synchronization to help with long-term trends? So this is kind of similar, but we've all been there where our medication refills are timed a week or two apart and it feels like we're at the pharmacy all the time. Is there something you all do to
Yeah,
help with that?
yeah. Actually, this is like a core part of how our pharmacy operates is, and how we can get some efficiency in our process is when a new patient comes to us who's not taking just one medicine, but they're taking a few. Um, I will, I and my staff will very deliberately pick a day that they're going to be getting their medicines with them. We'll usually center it around one of their highest cost medicines. And then we will do some smaller fills of their medicine so that everything else lands on the day where that one medicine is due. Um, and so by doing that, in the short term, it gets you from coming to the pharmacy every other day to coming to the pharmacy once a month or once every 90 days if you decide to go out to a 90-day fill, which I'm perfectly comfortable with. But it also, on an ongoing basis, my staff, we assign a so-called health coach to each patient that's enrolled in our synchronization, and that person will text you and say, "Hey, it's time to refill your medicine," and then we'll call you and talk to you about um, your medicines, make sure that we've got everything aligned, and then we don't always succeed, but we try to make sure that all of the little hiccups that you run into at the pharmacy get addressed between when we reach out to you before your medicines are due, usually about a week out, before you would run out of medicine, and we say, "Hey, let's make sure we've got everything sorted." So if your doctor sent refills and you're out of refills, we'll spend that week reaching out to your doctor saying, "Hey, let's get refills for Alissa." We'll make sure we have the item in stock for you, um, and then we can also coordinate delivery around that if that's necessary for your situation. But the process of medication synchronization makes a meaningful difference in terms of both the lived experience for you, but also for me as a pharmacist. I actually I implemented a when I was in pharmacy school. I implemented medication synchronization at the pharmacy I was working at, and we saw a 30% reduction in inbound phone calls to the pharmacy because we were beating people to the punch. We were saying, "Hey, do you need your medicines filled?" And we were reaching out to them. We controlled that process, and it lowered the level of stress and anxiety in the pharmacy dramatically. But it also, we saw more people get their medicines on time. We saw an increase in objective adherence. We saw an increase in the number of medicines, like the number of people that were adherent to their medicines, while at the same time, we actually reduced the number of times someone was going out the door with a delivery by about 12%. So it was a really meaningful thing for us. It improved our efficiency of operations, and it also lowered the stress level and increased the effectiveness of people's medicine, because medicines only work if you take them, and you can't take them if you don't have them.
Yeah, that's huge to offer that level of coordination, especially for someone that's on 5 or 10 or 15 meds with chronic diseases. It's a lot to keep track of, and good to have that support. I think we're going to take one last question. For an employer, the question is if a pharmacy desert forms in our rural headquarter location because the local independent closed, what does that do to my employees' health and outcomes? And does mail order really fill that gap?
Well, I mean, according to the Journal of the American Medical Association, mail order is probably not going to fill that gap, and you're probably going to see an increase in absenteeism, an increase in disease in your members, and so I think that figuring out how to prevent that from happening by saying, okay, where are the pharmacies that our members are using, and if there's a significant concentration in one pharmacy, just maybe have a frank conversation of, are you in, like, are you happy with where we are in terms of your reimbursement? Are we treating you fairly? Because I imagine that the answer should be yes, but if the answer is not, then that needs to be a conversation of, okay, well, let's move things around so that you continue to serve us, because we need you in our community. We need you to continue to service our members.
Most definitely. Well, thank you for sharing so many experiences and expertise. We do all want you to keep in touch, so please connect with us on LinkedIn. Additionally, if you have any other questions, you can email us at fulldisclosure@SmithRx.com. We also have great resources on our website with other webinars, including an entire one that we just did last month on PBM reform with Alan Paneer. So check that one out to do a deeper dive on the regulatory topics. Thank you for joining us, and thanks again, Benjamin, for being our guest this time.
Pleasure. Have a great day, everybody.